say hello and welcome. I am Michelle Pierce. I am the Primary Care Transformation Lead for the Middlesex London Primary Care Network. I see a number of you are joining, and I'm surely many more going to be popping in because this is a really exciting launch of the COPD pathway and certainly of interest to everyone. And I'm just wondering, I don't know if it's Dahlia or Drina is going to put the slides up for us.
Sidro will be putting it up.
Sidra's going to put it up. Okay, perfect.
Am I the co-host or shall I just simply share the screen?
You can share your screen.
Yeah, perfect.
Okay. Host has disabled participate screen sharing. I cannot do that right now.
You try right now.
Okay. There we go.
While we do that, I'll just go through the housekeeping. And we're going to ask you to please stay on mute if you're not speaking. So if you're one of the speakers today, we'll just let you unmute yourself. And as far as questions, I have to say, it's a very packed presentation that the COPD team has today. So I think we're going to ask to refrain from asking questions. We may have a bit of time at the end. We're not sure it's really a packed presentation for you, but the good news is they have an amazing resource for you, and we can certainly take questions after the fact if we do run out of time. And the chat will be available. And if you are signed as an iPhone, could you please rename yourself so that Dahlia can capture and make sure everyone that is eligible for Main Pro can definitely get recognized for that. And we want to remind you to sign up for the Middlesex London Primary Care Network newsletter. I want to add to that if you are a physician or a nurse practitioner. We have a lot that we offer you now with the new MLPCN, and please be sure to also confirm your membership with the MLPCN. So if we want to just go to the next one, I want to let our co-chair, Vineet Nair, talk a little bit about that for all of you.
Yeah, thanks, Michelle. Don't want to take much time here, but as you know, we've kind of made this transition, hopefully you know, from the London Middlesex Primary Care Alliance to the Middlesex London Primary Care Network. It's kind of a more formal group now as part and funded by Ontario Health through the Middlesex London Ontario Health Team. Wanted to keep our names kind of in sync with them. We really are trying to be this voice for primary care in our local area, and there's so much going on in primary care right now with, you know, all the parties talking about a lot of investment in primary care, the Jane Philpott work happening in that area as well. So it's kind of an exciting time to be optimistic about primary care. So we want to make sure everyone's involved and has their voice heard. So if you haven't already, I encourage you to go to that website. And if you're a primary care practitioner, nurse practitioner, family doc, to sign up, confirm your membership so we can really be that strong and legitimate voice for our sector. So thanks very much for attending today. And I might put something in the chat about a social event next week as well if you are interested in coming to a trivia night that we're having as a social event to try to, again, just improve morale and just have some fun as well. So, but thanks very much for coming tonight.
It's going to be awesome. I really encourage everyone to put a team together. On the next slide, Sidra, we just really quickly slip past that. We don't have any conflicts of interest here at the MLPCN and the MLOHT, and we'll hand it over to Sidra Jamal, who's a project manager for COPD.
Good evening, everyone. My name is Sidra Jamal, and I'm the COPD implementation lead for Middlesex OHT. I will be facilitating tonight's event. So what you can see on the screen right now are the speakers and their disclosures. Just a brief overview for all of you to see. I would like to hop on to the next slide to discuss the agenda. So I will briefly go over the objectives of this town hall, after which I will pass on the mic to Dr. Nicholson, who will be discussing COPD diagnosis, spirometry referrals, specialist referrals, and action plans. This will be followed by presentations from various community hub organizations, as well as Center of Effective Practice COPD supports. Dr. Aatika Imran will talk about health pathways and the overview of COPD supports and resources. As you can see, this is quite a robust agenda, and we want to facilitate you all in every way possible. So this slideshow will be available on the MLPCN website. The video recording of this presentation will also be available, and we will be dispensing a COPD supports and resource package to everyone in the town hall, where all the information discussed in this town hall will become available to you. And this resource packet would also be available on the MLPCN website. So having a look at the objectives, what we want to achieve tonight is practical tips on how to manage COPD diagnosis, practical tips on referring to community organization and implementation of action plans. We will be dispensing the program resources available within the region, as well as educational and palliative supports, and talking about a shared digital resource, the health pathways. I will now be passing on the baton to Dr. Nicholson, who is going to be talking about COPD patients on hospital discharge. Dr. Nicholson, you have the floor.
Thank you for that, Sidra. It's ironic because I'm on service this week at Victoria Hospital, so this is very near and dear to my heart for a few of the patients that we see that might be involved in some of the primary care teams here on the call, where we are trying to advocate for more accurate diagnoses of those that are at risk or actually have COPD. So often, especially in this time of year, we have individuals that are coming in to the hospital with viral infections, something that has likely triggered something underlying that we don't know about or suspect, but don't have a formal diagnosis for. So this is what we're going to try and optimize and work on as a care team, both from an inpatient perspective, but also as an outpatient, to optimize the diagnosis. And part of the way to do that is to actually perform pulmonary function testing. And some of those tests that we can optimally do in a quick turnaround is spirometry. So we're going to try and have a bit of a formal diagnosis made in a couple of weeks post-discharge for somebody who is suspected. And part of that is spirometry, and that's to help not only the follow-up plan with, say, someone like myself who is going to see them as a discharge follow-up from a respirology perspective, but also a family care team, a family doctor's office for a potential new or novel diagnosis. Some of these individuals don't necessarily visit the family doctor offices as much as they would or could. And then these are sometimes the types of individuals that we get through the emergency room that need a formal diagnosis. So essentially, we need to have a diagnosis based on pulmonary testing. There's a very few outliers that are without pulmonary testing abnormalities, or spirometry specifically abnormalities, that still have emphysema or COPD. But for a formal COPD diagnosis, it would be really advantageous to have spirometry. So we'd like to actually start to capture those that have not had spirometry, at least in our system, but have a high enough risk factor burden from a smoking history or exposure history, could be an ex-smoking history. Even if there's some suspected overlap syndromes, it's always important to get something diagnosed from spirometry. So our goal really is to book post-hospitalization a spirometric test 4 to 6 weeks out. And we're trying to optimize a pathway where we can do that in somebody who has not had a formal diagnosis, either from a family doctor office spirometry test or from a pulmonary function lab somewhere in the kind of southwestern Ontario location. So that's our idea for trying to have a suspected COPD case referred for spirometry testing when we are seeing them as an inpatient and trying to transition them back to outpatient and to their family doctors. It is the quickest and easiest test. Often we can get one of these tests done. We book them for 15 minutes, but that's to include kind of the pre-assessment by the RTs and then the cleanup or the wipe down of the machines afterwards. But they're generally only about a 7 to 10 minute test all told. So if we can optimize these in our facility at St. Joe's and Victoria Hospital for post-discharges, I think it's going to make some people have a diagnosis and start a pathway of management. They're a little bit different than full pulmonary testing, so it's not including body box plethysmography or diffusion capacity maneuvers, but it gives you a decent amount of information. And so if we're still needing further tests for full PFTs, we can do that, but it takes about 30 minutes to do one of those. So again, half the time to get some information, and a decent amount of information via spirometry is really important. Again, spirometry can be performed at a few different locations. Of course, utilizing what I know at St. Joe's and LHSC or Victoria, we can do them pretty quickly there, but these are also tests that can be performed in a physician's office. There's a couple colleagues that work in the community of mine that have access to spirometry as well. So this would be ideal, again, for somebody who is suspected to have COPD. So that's smoker that has symptoms, has come in with the pulmonary exacerbations. This is part of what our discharge pathway is going to hopefully involve, and that's part of our care teams also at the hospital that hopefully will come through with some of these information packages through the resource packet. Next slide, please. The time that I'm going to see somebody in my COPD clinic specifically, or a general referral to a respirologist, is for those that are coming in with a pulmonary exacerbation that need to be hospitalized, or recurrent exacerbations that you yourself are managing in your family practice. And then obviously those that are still symptomatic despite best or optimized care through medications. These are individuals that might have daily symptoms, nighttime symptoms, recurrent exacerbations, in the sense that they typically always exacerbate on a certain month of the year, or typically have, rebound exacerbations, or again, those that need to come into the hospital. These are individuals that often, are difficult to manage, or can be a difficult to manage type patient. So having the referral over to myself or one of my colleagues is very reasonable. And there's a few of us that do COPD more than others, and I'm happy or excited to hear and to share that we are hiring somebody as of the summer to help me in the COPD rehab program. So that's going to be very helpful, and hopefully allow more patients to be seen on that regard. Next slide, please. Part of what has come out recently is really how do we care for each patient specifically, and it can be difficult, it can be overwhelming, but having a written action plan is really important. And discussing this, there was a recent study that said, having this as an annual discussion is very important. So sometimes I see a patient who's been stable once a year, they have severe disease, but it's always nice to, go over those ideas from an action plan, of course, talk about vaccines, but it is something that, there's evidence, there's scientific proof to say having a discussion and then actually filling out an action plan, prescribing the medications, has better outcomes. So it's really important that we have that idea. There's a few action plan itineraries out in the into the Canadian literature, and trying to find the right one for you is really, something that you have to read through yourself, or feel like you have the flow through yourself. But we've come up with an idea of, some straightforward, simplistic action plans that you could use. Next slide, please. And so this is just one of those, kind of graphic information pathways I thought to share. That written action plan, the written care plan, shows that there is, better outcomes, essentially almost similar to showing somebody how to use their medication, not only inhalers, but also kind of when to use their medication. So writing it down and implementing it is really important. Who to call, how to start medication. So, this was just from the end of last year, 2024, in the BMJ. So I thought this was really important to show that, again, sometimes just taking a few minutes, I know we're all very busy, but having that written discussion and antibiotic or steroid action plan is really important, along with how to, let us know, or let the family practice know. Next slide, please. Again, this kind of comes back to how to refer or when to refer to somebody like myself. This was from the 2017 guidelines, but I still think it's very appropriate here. I don't expect anybody who is not a specialist to start to dabble into the world of azithromycin or roflumilast. It gets into the weeds on how to actually manage some comorbid conditions, and there's a few things coming out in the world of COPD that we might be able to optimize. So this is something where, although it is old guidelines, it is still very reasonable to consider a respirology referral when somebody not only has lots of symptoms, but also is frequently symptomatic and exacerbating. So I thought as a graphic to show that this is very important. Next slide, thank you.
Thank you, Dr. Nicholson. We'll be moving on to our next agenda item, which is different community hub organizations talking a bit about their work. So community paramedicine is the first one, followed by Best Care, Ontario Health at Home, and Team Care. Unfortunately, the folks at community paramedicine had a scheduling conflict. They could not come in. They have sent in their slides, and I will be the one presenting them. So I request the audience to please put your questions for community paramedicine in the chat, and we will make sure that the answers get back to you. So community paramedicine is the non-emergent mobile response team, and they work in collaboration with the patient's primary care providers to provide a range of community-based primary care services, and they can be provided in the comfort of a patient's home. They operate 24/7, 365. So the question can arise when to contact community paramedicine. It is important to remember that community paramedicine is not a replacement for primary care or 911. So the time to connect with them is if a patient is experiencing an early onset to acute flare-up of COPD and are unable to access their primary care provider, they can choose to contact community paramedicine for non-emergent responses. Or if the patients have an appointment booked with their PCP, but are experiencing an early onset or acute flare-up, they can choose to self-refer to community paramedicine. So the community paramedicine team can offer medical management of acute flare-ups, palliative care, pain and symptom management. They do provide motivational coaching, educational, and self-management guidelines. They work in collaboration with healthcare providers, and they do refer out to community resources and support programs. So some of the relief and symptom treatment plan options offered by them include consulting with the primary care providers. Their treatments are the ones which are prescribed in the community paramedicine patient care standards. They can consult with the on-call primary care support team prior to administration of treatment if the need arises. Community paramedicine does monitor and offer follow-up. They offer transport to emergency department when appropriate in alignment with the patient's goal of care. They are required to notify the PCP when the treatment is provided without direct orders, and they follow up the patient at 24, 48, and 72-hour marks. What you can see right now here is the list of medications that community paramedicine can provide up to 3 days to patients with COPD. I will now pass on the mic to Alison Keller from Best Care. Alison, you have the floor.
Hi, everyone. It's so nice to be here tonight. I'm Alison Keller. I am the project lead with Best Care under the leadership of Dr. Christopher Lishka, a respirologist in your London region, and Madonna Ferroni. Best Care is a proven and measurable value-based chronic disease management model we're going to learn more about tonight. Next slide, please. So just to set the stage of who we are a frontline clinical program led by a community board of governors who you see here. And Best Care has been around since 2003. We are funded by the Ontario Ministry of Health and currently operating in more than 300 primary care offices across Ontario. Next, please. Oh, we just went too far. Thank you. So what is our approach to primary care chronic disease management? Best Care is an effective model for this chronic disease management by being a repeatable platform for multiple chronic diseases. We currently have an asthma, COPD, congestive heart failure, and AFib program. Best Care really is an instrument for health system transformation by empowering primary care. This is a complete knowledge translation interdisciplinary program. Best Care is in person, it's evidence-based care. We embed educators, case managers who are guideline experts right into the patient's medical home. Our team consists of respiratory therapists and registered nurses who have been upscoped to be these guideline experts. Best Care is proven upstream preventative care, aiming to reduce hospitalization and ED visits. We support system transformation by building primary care as the foundation of the system. Next slide, please. This is a bit of a tongue-in-cheek slide we use, but what are providers asked to do in about a 7-minute encounter with their patient based on the guidelines? It's everything you see here on this list. It includes pre and post spirometry to confirm or rule out a diagnosis. We're expected to differentiate between COPD and asthma, initiate inhaler treatment based on guidelines, and ensure that proper technique is being done every visit. Monitor patients' adherence, teach patients about their COPD, write an action plan to support self-efficacy, support smoking cessation, manage exacerbations and see them urgently when happening, and ensure proactive identification and proper follow-up. Pretty hard to do in 7 minutes. Next slide, please. So how does it work in the clinic? Designed by primary care providers, Best Care embeds an RTRN, who's a CRE, right in the practice, seeing the patients. We see about 5 to 7 patients a day, a mix of initial and follow-ups from all providers within the clinic. And we ask for about 5 to 7 minutes of that provider's time per patient. By the end of the Best Care appointment, the patient leaves with all evidence of evidence-based care. Their diagnosis confirmed, their medications reviewed, recommendations made based on guidelines, education. They have an action plan with a prescription when appropriate. The frequency of the visits varies based on the severity. It could be 3 visits a year or 1, depending on the severity, but it's a continuing care relationship. Next, please. An example of some of the heart health quality reports we generate. So how can we ensure that we're doing these at every visit? Because we collect data every time. We have our own EMR and our staff monitor exactly what they do. So we can say with certainty how much spirometry is being done, how many exacerbations are being assessed, comorbidities. This is a complete kit providing all elements of care for pharmacological and non-pharmacological. Next, please. So this is a really Best Care, a scalable health system. We've had exponential growth. 100% of providers say yes to Best Care when approached to have them in the clinic. As I said earlier, we are operating in over 300 clinics across Ontario and actively working with 1,600 primary care providers, family physicians, and nurse practitioners. Our high-risk COPD cohort for last year was 8,800 patients, and we did 19,000 spirometries in primary care in 2024. Next, please. I'm going to show you a little bit of our data from our COPD population. Next. On the left hand of the screen, we're looking at our results from our randomized control trial. On the left there, we see the Best Care data, and that is reference to the control group, which were family health teams where Best Care had not been implemented. And we're looking at a CAT score change. So we can see with the Best Care population, a reduction in the CAT score compared to the control group where there was an increase. On the right is the results from our interrupted time series that we're very excited to share. These were published in Thorax this past year, and it's with 2,400 of our COPD patients. So just to orient you with what you're looking at, time 0 there is the first appointment in Best Care. So using ICES, so that's OHIP data, we calculated the rate of the hospitalizations for the COPD patients for 3 years prior to COPD, really specifically looking at our gold E patients. So patients with hospitalizations or two or more prednisone requiring exacerbations within a year. And what you can see is a very steep upward trend of hospitalizations. First appointment with Best Care is at time 0, and there is a drastic drop in hospitalizations, and then there is actually a decreasing trend for the next 3 years. Next slide, please. Thank you.
Yes, that was the end. Thank you so much, Alison Keller. And I would like to remind everybody in our audience that all the information that is being shared about these health organizations is going to be part of the resource packet, so including some referral forms, so you will be able to connect with them. Next, we have Jessica Law talking about Ontario Health at Home, telehome care, and CC2H programs. Jessica, you have the floor.
Thank you. Hello, I'm Jessica Law. I'm a Patient Services Manager with Ontario Health at Home, and I'm here with Lori Elder, Director of Patient Services. Next slide. So we are Ontario Health at Home, formerly known as Home and Community Care Support Services, but I'm here tonight to share some valuable information about 2 of our specialized programs offered by Ontario Health at Home to support patients with COPD. So our telehome care program and the Connecting Care to Home program. Next slide. So first I'll talk about our telehome care program. Next slide. So what is telehome care? Telehome care is a province-wide virtual self-management program, and it's designed to help patients with COPD. So with the virtual support of a registered nurse, patients receive guidance, coaching, and ongoing support to manage their condition. The goal of the program is to support patients in their home, and it's to help them better understand how to manage their COPD, identify changes or concerns early, and prevent emergency room visits and hospital admissions where we can. So patients can be enrolled in the program from the community as well as part of their plan to transition from hospital to home. Next slide. So there are 3 pathways available here in the Southwest with our telehome care programs. We have our COPD pathway, our heart failure pathway, and our COVID pathway. All these pathways can be run together at the same time, so it doesn't have to be one or the other. And these programs do run in length from 2 weeks to 6 months, but I'll be focusing on the COPD pathway today, which is about, on average, 4 to 6 months in length. Next slide. So the program works by loaning patients equipment to help them self-monitor and manage their health at home, like I said, with the virtual support of a nurse. So this the virtual support can be done by phone, or it can also be done by video conferencing with the nurse, and that's where the tablet they would get as that part of that loaned equipment. So every day the patient would be expected to check their vital signs, answer a series of health questions, how they are feeling, and this is also to address any changes in how they're in their health. The nurses will monitor that information that does come in, and anything that falls outside of that normal range typically prompts a phone call from the nurse. And from there, they will complete an in-the-moment health coaching session, talking about how the patient is feeling, providing some guidance on next steps, how to manage their symptoms. But if the patient's doing well on the program, then they are being contacted by the nurse about once every 1 to 2 weeks. And there we provide structured education sessions around managing their health. So as a primary healthcare provider, the telehome care program could be used as an extension of the care you provide. So we typically provide regular updates while the patient's on the program, as I'll keep you in the loop of also if there are patients also having any issues or concerns. Next slide. So here I just want to highlight some positive feedback we have received from patients who have gone through the program. Typically, some of the positive feedback we are getting is that patients feel the education provided in a way they can understand and how the nurse will be able to help avoid emergency room visits and hospital admissions. Next slide. So as I mentioned, the telehome care program, it is a province-wide program, and we do have a standardized eligibility across the province. And this includes patients who are 18 and over, as well as having either the patient's unable to participate physically with the equipment or the health coaching and education provided, a caregiver can also support with that as well. Next slide. So when to refer to the program or how to refer to the program, you can just mark off COPD on our general Southwest Ontario Health at Home referral form. And that can just be sent in normally as you would with any other referral. Additionally, you can mark off COVID or heart failure at the same time. And the referral form can be found on Ontario Health at Home public website. And it is included in that resource package that Sidra had mentioned earlier at the beginning of the meeting. Next slide. So our second program, we're going to talk about our Connecting Care to Home program, or also known as CC2H. So our CC2H program was established in 2015, and this was to support patients transitioning from hospital to home. So it is a partnership between the hospital and the community to ensure patients receive increased wraparound support to promote a smooth transition from hospital to home. So as a primary care provider, we want to make you aware of this program, as any COPD patient that could be part of your practice, who is possibly admitted to hospital, could come home with this program. And if the patient is enrolled in the program, you would receive regular updates while the patient's going through the program, as well as possibly receive invites to attend care conferences. Next slide. So here, just kind of, I'm trying to explain how do we wrap around the patient. So we have kind of like 3 separate teams trying to support the patients. There's a acute care team, there's a community team, and there's a bridging team. And that bridging team is really to help ensure the patient is really fully supported going home, and ensure that anything that does arise while the patient is transitioning would be able to escalate any of those clinical concerns going back to the MRP. Through the hospital site, or also looping in primary care, or ensuring that they also are getting the home care support that they do require. So we do use a shared platform, and that's used to connect the entire team. And this is as a way of communication and monitoring for the patient. Next slide. So patients part of the program are provided education on how to manage and identify changes in their health. They are supported a mixture of in-home and virtual support to transition from the hospital and to be supported at home. Next slide. So this is to highlight what a typical pathway looks like for a patient. So the patients are typically identified in hospital. So unfortunately, patients are only enrolled into the program if they are admitted to hospital at this time. And then based on an assessment, the patient will receive a mixture of in-home and virtual visits by nurses and allied health services. Our clinical care coordinator, who is a registered nurse, will aim to visit the patient within 48 hours of discharge from the hospital, and then they complete a clinical assessment in the home and support the patient. As the patient transitions through this journey home, they will receive video conferencing with members of the hospital team, so the hospital navigators, the most responsible provider, as well as community healthcare teams will also take part in these meetings. And this is just to ensure the patient is progressing well at home, they're transitioning well from acute care to community. And as a primary care provider, you may find that you might receive invites from Ontario Health at Home to attend these meetings. And this is just to promote a warm handover as the patient stabilizes at home. And we do understand that time constraints can make it difficult to attend. So we do welcome actually any support from any clinical members of your team. And then near the end of the CC2H program, the patient will be supported with ongoing community supports as they require, and may even may be referred to our telehome care program, as I mentioned previously as well. Next slide. And this is just highlighting the typical patients who we see typically enrolled in the program. And as I mentioned, typically they are enrolled right now from hospital and are identified in hospital as well. But like I said, I want to make you aware of this program because it may not be uncommon to see some patients transitioning from hospital to home with our CC2H program. Next slide. And thank you.
Thank you so much, Jessica. And all these resources and supports will be part of the resource package. Now on to team-based care at London Community Health Centre. Renee, you have the floor.
Hi, my name is Renee Primo. I'm a systems navigator with London Intercommunity Health Centre at the Argyle location. I also am supporting the PAP and prenatal clinic, and today we'll focus on team-based care as it relates to all different resources, not just respiratory therapy, but that's also included in what we can offer primary care physicians. Next slide. So the objective of today is just to quickly learn about LIHC and some of what we offer and our goals and mission, learn about the flow, and then near the end to gather essential contacts. And I'll have my contact there that you can definitely send me your contact if you're interested in registering or if you have any further questions. Next slide. So a CHC, a community health center, we're a nonprofit community government organization using interdisciplinary teams to offer health and social services. So our main goal is to limit barriers to care for folks who are facing large barriers to care based on things they could be facing in their life, whether it be low income, substance use, anything that may stigmatize them or prevent them from accessing quality care. And we aim to limit those barriers and increase accessibility. Next slide. Our 3 site locations, the one that you may be most familiar with is our 659 Dundas Street location, where health outreach and front-facing homelessness is typically served. Then we have our 1355 Huron Street, which is mainly primary care. And then 1700 Dundas Street is where I work out of and where we have our team care program and also the newcomer clinic. Next slide. So team-based care, it offers support to primary care physicians that don't have a team. So especially with the physician crisis and having more limited resources than normal around this time, we're trying to increase our support of primary care physicians so they don't feel like they're alone in their practice, and we can create wraparound supports for their patients. With team care, we just create as many supports as we can for that patient to support that physician. Next slide. The eligibility, so we want people who are struggling with barriers to care based on the social determinants of health. And while we prioritize the East End of London, that's not necessarily the criteria that they need to have. That was originally with our original funding, but now we can serve more people. If you feel like the patient is struggling with barriers to care based on the social determinants of health, you can refer them, and then we'll see if we can connect them internally or externally to the center. Next slide. So some of the history, so it was previously called Pinot. So we've changed the name so it reflects more of our health-centered approach. So so team care is, our catchment area actually is all of London now, as long as we have the resources to support. So we've moved back towards that way of serving our community. I'm the primary contact for that. And we're based on the model called SPIN, which was in Toronto, solo practitioners in need, just identifying that solo primary care physicians need more supports, and we wanted to create a way to offer that for them. Next slide. So the process is registration. So that is through contacting myself. My contact information will be up on one of the slides, or you can go to our website, which will also be up on one of the slides to register there. Then I would reach out to you, send you the referral forms, and connect with you in that way. You can refer your patient to us. Our client care support worker books them into my schedule, or if somebody else is supporting me, their schedule. We do the intake with them, and then we identify what barriers they have, what services they may need, and then connect them to those services. We also follow up with the physician with information following each appointment, just so that you know what we've done with your client and where we're sending them and connecting them, and to get feedback from you as well. Next slide. So these are some of what we have available for your patient. So you may send them for one thing, and if needed and wanted, we could connect them with all sorts of different types of services. So we have foot care, we have HIV and hepatitis C testing and treatment, physiotherapy, poverty and homelessness programs, seniors, youth, and women's programs. I'll also add newcomer programming as well, respiratory therapy, social work and mental health services, and diabetic care, and the dietitian services as well. And we offer interpretation services for all clients for every appointment if they need that. Next slide. So these are, this is my contact. So if you'd like to reach out with any questions, or if you're interested in registering yourself, you can feel free to do that. Anne-Marie Sanchez is our director and was one of the original founders of this program there as well. And that's our registration link for the site if you'd like to register. And that's all.
Thank you, Renee. And again, all of these resources and contact information is part of the resource packet that will be disseminated to everyone and part of the MLPCN website as well. I am now handing over the mic to Nicole Seymour, who's going to talk about Center for Effective Practices COPD supports. Nicole, you have the floor.
Hello, thanks for having me. Next slide. For those of you that don't know the Center for Effective Practice, aka CEP, CEP, or the Center, it was established in 2004 through the Faculty of Family Medicine at U of T. The organization has since branched off on its own as one of Canada's largest independent not-for-profit knowledge translation organizations for primary care. Recognizing that with all the ongoing studies, guidelines, and new things in general that primary care is being asked to juggle, it is difficult, and some would even say impossible, to keep up. And CEP's goal is to bridge that gap between evidence and practice in primary care where possible. Next slide. CEP does this through a number of different tools and services for primary care. Next slide. These are all developed in collaboration with various stakeholder organizations. Next slide. CEP is most well known for their clinical tools that are all available for free online at cep.health. You might have heard of their core back tool, the COVID-19 Resource Center, the Poverty Tool or Social Prescribing Tool. Today I'll mention the COPD tool. Next slide. There's also the Provincial Primary Care Academic Detailing Service that I'm a part of. Our academic detailing service provides free one-on-one educational discussions between a clinical pharmacist and a family physician or nurse practitioner to discuss best practice. Next slide. CEP was inspired to bring academic detailing to Ontario after learning that many other jurisdictions globally have been offering it as a key support to primary care and can provide a 2-to-1 return on investment. CEP has partnered globally to optimize its academic detailing service. Next slide. Since 2018, more than 1,600 physicians and nurse practitioners across Ontario have received one-on-one support. This has been funded by the Ontario Ministry of Health for family physicians, primary care nurse practitioners, and family medicine residents. Next slide. All of our academic detailers are clinical pharmacists that also maintain a clinical practice. We all have a strong foundational experience in pharmacotherapy, clinical evidence appraisal, and are free of commercial interest with extensive training. Next slide. I am the local academic detailing pharmacist. I am in London. I worked at LHSC for many years, and I currently maintain casual work at St. Thomas Elgin General Hospital, as well as some consulting with RX Files and the National Resource Center for Academic Detailing. I have no commercial disclosures, no grants, speakers fees, or consulting fees outside of what I've listed. Next slide. All of our academic detailing training involves oversight by a physician with expertise in the area. For COPD, our clinical lead was Dr. Tony Durzo, who was involved in the CTS COPD guidelines. Next slide. For an academic detailing visit, basically we sit down and we figure out, what does the provider want to know? What are they seeing in their practice? What questions do they have? What questions are they getting from other healthcare providers, from patients? What are they seeing from specialists that they're not sure how to follow through on in terms of the follow-up and refilling the prescriptions? I'll answer all of those questions in real time, and I'm also available for ongoing follow-up visits or troubleshooting through email. Next slide. This academic detailing service can be done in person or virtually, usually 30 to 60 minutes, but can be as little as 15. It is Maine Pro accredited with no industry funding, and really the goal is to enable practice change. Next slide. We have some pretty good results for having family physicians increase their ability to practically translate evidence into primary care per self-reports, as well as some actual prescribing trends, reductions in opioid prescribing and benzodiazepine prescribing from our earlier topics. Next slide. Compared to other forms of CME, academic detailing is a little more interactive. It is more practice facilitation-esque. It's personalized to the provider at a time that works well for them with no industry involvement, lots of follow-up, and it's relationship and resource-based. Next slide. As you may have guessed, COPD is one of our topics. We also have pharmacotherapy for obesity, anxiety and depression, type 2 diabetes, heart failure, and we'll be launching ADHD in adults in the near future. We do add 2 new topics per year. Next slide. For COPD, common things that clinicians will ask to talk about are just, let's talk about the inhalers. What is a Genuware? I've heard of it, but I've never seen it. I've never used it. How do I actually implement a COPD action plan? What resources are there? I heard something at this town hall. Can you remind me of which email I need to go back to kind of look into these things? So these are the types of things that I can help providers navigate or answer questions for. Next slide. To learn more about academic detailing, you can go to CEP's website. If you are with Thames Valley Family Health Team, your family health team pharmacist can do the academic detailing with you or direct you to someone that can. I am the local academic detailer for all of the other sites outside of Thames Valley, so you can scan this QR code, you can email me, or you can sign up through the website. Next slide. CEP has many other resources, as I mentioned, the clinical tools that you can see at the top of our homepage. Next slide. If you click there and then scroll down, you can see the COPD tool. If you click on that, next slide, you'll get to their landing page where you can click on the tool or go to academic detailing, which is another sign up right there. So next slide, you'll go into the tool, and we do use these tools for academic detailing. All the information is there if you want to peruse at your own leisure. And next slide, all of that information is also built into EMR tools called Evidence to Practice, or E2P. This is basically taking all of the clinical information from the guidelines that's already been collated and putting it into an EMR at your fingertips in real time. This is a collaboration with CEP, the eHealth Center for Excellence, and North York General Hospital. And it is available in Oscar, TELUS, PS, and Accuro. You can see that you've got the screening and diagnosis, management plan, and then lifestyle referrals and follow-up, all of that available right at your fingertips. Next slide. You can sign up through our website again, and I do encourage you to also sign up for an optional change management specialist appointment where they can demo the tool, support the install, and answer any questions that you may have. Next slide. Last but not least, this is again our homepage. You can see the signups for more information on E2P, our clinical tools, and academic detailing right there. Thank you so much.
Thank you, Nicole. The time is now 7:47. We have flooded you all with a volume of information, which will be available in the resource packet, including CEP's homepage and referral forms. I will now pass on the mic to Dr. Aatika Imran, a familiar face at MLPCN. Dr. Imran, you have the floor.
Hello, everyone. So just like me, you were all probably thinking there are so many things that I didn't know about. So this is why Middlesex London Ontario Health Team is collaborating with Burlington and Hamilton Health Teams, and we are bringing the health pathways to Middlesex London. It is, as we call it, is one source of truth for the primary care providers. Next slide, please. So it will be accessible to all primary care providers within the region, and it will include clinical guidance as well as systems navigation. So for example, COPD pathway will provide guidance about the assessment, diagnosis, testing, management, as well as the resources that are available in community. So simply put, you spent your last hour learning about all these services, and these will all be available for you to navigate through the pathways. So as you can see, there are clinical aspects of the pathways as well as the services available through the pathways. The pathways, the information on the pathways is definitely evidence-based, but we are continuing to update it regularly as we go. And there is also a feedback button for the providers. So if you have any feedback, you can just click on it. Next page, please. Middlesex London will be launching the pathways. We are very excited about it, and we are working very hard towards localizing 50 pathways. Once we are up and running, our aim is to localize all 700 pathways. I encourage everyone, next slide please, to look forward to our launch in June. If you want to know when and how we are launching, please scan the QR code. The pathways are free, accessible for all primary care providers to use. It's available at the point of care for everyone. It's just a one-stop shop where all the referral sources we have heard about for many diseases will be available in one page while you're seeing the patient. And it will just be accessible in your office free of cost. So I encourage everyone to scan the QR code and look forward, as I am, for June. Next slide. I was giving time for everyone to scan the code. So as we all know, the natural course of COPD and the evidence is that we need to involve palliative care at some point. Palliative care resources are available in community. Some of us are familiar with PCOT and all the resources, but the palliative care resources will be available through pathways as well. Next page.
So go ahead, Dr.
So
Mala.
yes, so basically this is it. Just to sum it all up, you have the resource package that contains everything that we have for now. And then in June, we will bring forward the health pathways. That will be one click to whatever you need to find while you are seeing your patient. Thank you.
Thank you so much, Dr. Imran. And this brings us to any questions from the audience at this time. The time is 7:51, so we have a few minutes. And if it's okay, I'll stop sharing my do you want me to stop sharing my screen? I don't, or I can put the questions in the chat.
I would stop sharing so that we can see everyone's faces and it's easy to identify their hands.
Sure.
Yeah. That was just incredible. Wow, that was a lot of information. But clearly so much work has gone into that. So like such great resources, well put together. That's surely going to be amazing for all of primary care. And maybe we don't have any questions.
And I'm gonna just jump in and say if there are any questions to any of the organizations that that presented, or if there were any questions for Dr. Nicholson as a specialist, this would be the time to, you can put your hand up and ask those questions.
I think that's a sign of a really well put together presentation. No questions so far. You know, you may get more questions come in as we post the video. And also a reminder goes out through the MLPCN newsletter. There will be another one next month or well, shortly after this. I can't, Drina, I can't remember how many days, maybe in a couple of days, we'll post the recording probably. And that will go out to anyone that was unable to attend, had a conflict this evening. We had respondents from over 60 people, and I think we had a little over 50 here. So it looks like there were a few people even that had signed up that didn't make it on tonight. If I may, I just want to thank everyone from the team here that presented today from COPD. That was like super engaging. Just so many rich resources. So let me just mention here, we had Dr. Michael Nicholson, Sidra Jamal, Dr. Aatika Imran on our MLPCN Executive Council, Alison Keller, Renee Primo, Jessica Law. So, and, you know, of course, Miriam, I know you're part of that team. So just such fantastic work. Miriam is the manager of Health Pathways. If I can plug, is it okay if I mention the SIM, Miriam? We have a symposium coming up.
Absolutely.
Thank you. I didn't, because it wasn't mentioned there, and I thought, oh, maybe there's a little hesitancy to you wanting the QR code. I didn't want to be a spoiler alert there, but we do have our first MLPCN symposium. It is going to be on June 11th, and it's a Wednesday. So save the date for that will be coming out shortly, and that is going to be the major event for the Health Pathways launch. And we're also going to provide lots of other educational opportunities at that to support chronic disease prevention and management for primary care. And that is, open to anyone in our primary care audience. We hope that you'll participate. I want to plug again for March 6th. So I heard the expression from when I was at the Durham event with Jane Philpott, that there is joy missing from primary care. So we are bringing you joy with a very exciting and fun trivia night on March the 6th. That's Storm State Brewery. It's a professional facilitator. So just come out, have some fun, and collaborate with your colleagues, meet some new people, have a few laughs. And I know that there's a lot of competitive spirit out there in primary care. So we can even get some healthy competitive going out. April 11th, there's going to be another event coming up too for strategies for a profitable practice. So any primary care clinics out there that if you're struggling to be as profitable as you had hoped your practice could be, there's led by Andrea Lowen and some other folks. She's obviously our recruitment and retention lead for the OHT, and we have some other folks that are going to be presenting as well to help out with some strategies for that. So those are some things that we have coming up. All of the events for MLPCN, as well as the Department of Family Medicine, as well as the help me out, Vineet. I'm trying to remember the other physician organization.
London District Academy of Medicine.
Thank you. Thank you.
Yeah.
I was having a bit of a senior moment there. London District Academy of Medicine. We have collated all of the events on the MLPCN website because the feedback we got was that there's so many events and webinars and things going on for primary care, and they're all over the place. So we're trying to collate that. And certainly if you or your organization has something that's important to primary care and you want us to put it on our calendar, please email us at hello@mlpcn.ca, and we will certainly add it to our calendar as well. So just want to scan and see if there was any more questions that came up for the COPD
There's a hand
team.
up, Michelle. Dr. Imran's hand is up.
Perfect. Go ahead, Dr. Imran.
I just want to thank Dr. Nicholson. We were sort of steering it towards primary care, and I didn't want to ignore you. Thank you very much for your support. You have been very patient with us for months now. And I really, really wanted to acknowledge Miriam and Sidra. It was very organized, but the pathways, the whole work, the whole foundation, we will not be able to share how it was such a little seedling, and now it's taking shape. So we are very excited to bring this work forward for everyone to share.
Amazing. Thank you. If there's no other questions, I'm just going to hand it back to Vineet and as our co-chair for the MLPCN.
Well, thanks, Michelle. No, thanks everyone for joining us tonight. Yeah, with lots of good information. It really is amazing how much wraparound services you guys have covered every step of the patient experience with this, which is pretty impressive. So, and the provider experience too, as far as if we need help in any of the stages, it's really, there's something there for everything. So it's pretty impressive. So it's really quite the model for other illnesses, I would say. Well, the care of other illnesses, let's say. But no, thanks everyone for your time today. I think we'll give you an extra half an hour back today. So we get everyone's had a long day, I'm sure, and it's been nice to have everyone here tonight. Thanks for attending.
Thanks, everyone.
Thank you.
Thank you, everyone. Good night.